everyone has suffered from dry eyes at some point. But did you know that not all dry eye is created equal? In this episode of OCuTALK, Dr. Julian Prosia will discuss the different types of dry eye, how different conditions and medications impact the tear film, and how important healthy eyelids are to healthy eyes. Dr. Prosia?
I want to talk to you.
Not now, later.
No, now.
Hello everyone, and thank you for joining us for a brand new episode of OCuTALK. Hello everyone, and thank you for joining us for a brand new episode of OCuTALK. My name's Nick, and today we have a very special guest joining us. Please welcome Dr. Julian Prosia. Dr. Prosia, thank you so much for joining us today.
Thank you for you guys having me today. I appreciate it.
Well, absolutely. Thank you for taking the time out of your day to visit with us, Dr. Prosia. Before we actually get started with our questions, would you mind actually introducing yourself to us? Let us a little bit know about your background and your specialty, and maybe a little bit about your practice.
Yeah, absolutely. So I'm actually originally from Canada. I grew up in a small town called Ancaster, which is about 45 minutes, 50 minutes from Toronto, which I'm sure a lot of people are aware of and know the area there. So I started as an ophthalmic technician working for a really, really good practice back when I was in undergrad. The owner at the time, her name was Dr. Judith Parks. She was phenomenal. She really forced me into the eye care profession. So after I went to McMaster University, finished my honors of Bachelor of Science, I went to Nova Southeastern College of Optometry, and I'm currently still working in South Florida. So I stayed down here, decided not to go back to the motherland, but it's been great. So now I'm working at Westbrook Eye Center alongside Dr. Brent Ballot, who has been an absolute amazing mentor and friend. And the way that we run our practice is a little bit different from a standard practice modality. So, I've interned at a couple different, OD, MD practices, and usually you would think, a lot of MDs and ODs are working together concurrently right beside each other, but it's not usually like that from what I've seen. A lot of the ODs are doing their own thing over here. The MDs are doing their own thing. It's kind of split. But with me and him, it's just him and me. And so we're constantly in and out of rooms talking about patient cases. And so we're basically an extension of each other. And it really helps because I take all of the dry eye and he takes all the cataracts. And so with good, dry eye, you get good end result in cataract surgery, and we'll talk more about that later. But that's essentially how we run the practice, and it's been absolutely phenomenal. So, yeah, that's a little bit about me.
Well, fantastic. Thank you for that introduction, Dr. Prosia. And again, thank you so much for joining us today on OCuTALK. So like you said in your intro, you take the dry eye side of things. So for our topic today, we were actually hoping that maybe you can go into a little more in depth with our audience about dry eye and how maybe, we all know not all dry eye is all the same. So how many different types of dry eye are there?
So in order to understand what dry eye actually is, we actually have to understand what a healthy tear film means. And so what the healthy tear film is it's essential for comfort, optimal vision, and integrity of the ocular surface. And when I say ocular surface, I'm talking about the front surface of the eye. And so this tear film is very important because it protects the front surface of the eye or the cornea from the environment and any infectious insults, also providing the necessary trophic or growth factors to maintain good health, promote healing, not only to the cornea, but surrounding ocular tissues. So now that we kind of understand what a functional basics of a tear film, we can kind of look into the DEWS study. That's a famous study. It's called the International Dry Eye Workshop Study. And essentially it labels dry eye as a multifactorial disease. When I think of the word dry or dry eye, the first thing that comes to mind is inflammation. And so this multifactorial problem of inflammation leaves our patients with visual disturbances such as vision that goes in and out, which is a huge one. Burning, itching, redness, tearing, headaches, fatigue, straining. And all of this is due secondary to the fact that there is this upregulation and inflammation on the surface. And so over time, that chronic inflammation leads to further deterioration, specifically of the nerves. And so now we have that, we hinder the ability to properly heal the eye or produce tears. And so going into how many, different types of dry eye there is, we can break it down into two main groups, our aqueous deficient, and we have our evaporative dry eye. And so our aqueous deficient can be divided into like Sjogren's disease or a non-Sjogren type syndrome. But the main cause or the main bulk of dry eye is essentially evaporative, the evaporative version. So focusing on the evaporative version of dry eye, it's the most common form of it is due to meibomian gland dysfunction. And this is something that's really, really picking up in the last couple of years because we don't really have too many amazing treatments to treat MGD. Yes, we can manage it, but there's no cure. And so focusing in on what MGD is, it's essentially just this obstruction of the terminal ducts or the glands that secrete this lipid. And without this lipid, the tear film can evaporate. And so you can see how that could be a problem. So we really have to kind of look deeper into what type of dry eye it is in order to provide the patient with a proper management and in order to see, good success.
Well, excellent breakdown, Dr. Prosia. Thank you for that. And so what are the major distinctions? Like how are they different anatomically speaking?
Yeah, so the two major distinctions or the major distinctions of these two main groups is that for our aqueous deficient dry eye, it's a direct functional downregulation of the lacrimal gland. And what the lacrimal gland is, it's essentially releasing that aqueous, which is about 80 to 90% of what our tear film is. So that's a little more rare. I'd say 20% of people actually have an aqueous deficient problem. But that's where that idea of Sjogren's disease comes into effect. Or if there's some nerve issues like diabetes can actually have, neuropathy that causes a downregulation in the lacrimal gland functioning. But in terms of the opposite, which is the evaporative, we think of meibum, which is actually the top coat or the protective coat of the ocular surface. And in that form, that is actually downregulated. And that's coming from the indirect inflammation of the lid. And so that inflammation of the lid, it swells the glands shut, and then you don't have that fluid coming onto the surface of the eye. And so once you lack that, then you have the secondary evaporation of the aqueous. And so, we have to really look at the fact that anatomically they're different, and that gives us some good insight into whether we treat the lids versus we use something different to treat the lacrimal gland directly, or the secretions that pertain to the lacrimal gland.
Well, again, excellent information, Dr. Prosia. And so now that we kind of gone over the distinctive type of differences, what does your diagnostic process look like for your patients who come in with dry eye symptoms? What does an average visit look like for you?
Of course, yeah. So when it comes to diagnosing dry eye, it's never a cookie cutter type situation. When we're thinking of dry eye, it is actually by far the most prevalent eye diagnosis across North America, Europe, Africa, Asia. But yet only 5%, believe it or not, are properly managed. It's heavily, heavily underdiagnosed. And so this is why, as physicians, we need to pay attention to a multitude of things when considering if this patient may or may not have dry eye. So if you're looking at, is it possible for a patient to self-diagnose? It's almost impossible for them to self-diagnose. Yes, of course, like they could feel the symptoms and feel like, yeah, it could be dry eye. But when it comes down to actually diagnosing it at home, it's virtually impossible because there's just so many different variables that go into dry eye. Now, when it comes to dry eye, symptoms are number one for me. Taking a good history is very key. So I always conduct a thorough examination that involves, present history of comorbidities such as glaucoma, diabetes, autoimmune diseases, thyroid problems, any medications they're taking. And a lot of doctors, believe it or not, I feel overlook this because, it's something that we don't really, take as interesting. It's, have the tech do the history, but we have to really look into it because a lot of these comorbidities or medications can actually lead to dry eye or the signs and symptoms that these patients are experiencing. Specifically at my practice, what we do is we fill out an OSDI, which is essentially a questionnaire before the patient sees me. And what that does is it quantifies by number, what the symptoms and signs are. And so with dry eye, it's a qualitative problem, but if we're able to get a more objective measurement or quantify it in a different way, it makes it better for us as physicians to make a decision or to quantify whether they're mild, moderate, or severe. So that's very important. Now, when I get into the room, I do a multitude of things. Number one, I put the sodium fluorescein stain in the eye so I can evaluate all the ocular structures. And especially for patients who have any comorbidities with diabetes or thyroid, I actually do a cotton swab sensitivity test. This is something that I feel not too many people do, but it goes a long way and it's really easy to do. I basically just take a cotton tip and I touch the front surface of the eye. And what that does is it kind of registers to the patient, can they feel it? If they can feel the pain. And we know that if someone can feel the pain, then they have working nerves that is going to help them produce more tears, heal. And so that's very valuable, especially for, patients that could have very, very severe forms of dry eye, and yet they're not feeling the symptoms. And so that's a really good measurement that I think a lot of people could incorporate into their practice. And so we start with that just as a basic screening. If you're looking to get into dry eye, you don't need a lot of diagnostic equipment. It's simply just a lot of knowledge and using the slit lamp and stains and just looking closely.
Well, fantastic information, Dr. Prosia. And so you talked a little bit about your diagnostic, walkthrough that you do with your patients when they come in. So how do the symptoms differ? And I know you kind of talked about it a little bit beforehand, like as patients, we're not going to really know exactly or self-diagnose. But can we kind of tell like what type of dry eye do we have, or is that not the case?
Yeah, so that's a very good question. It's tough to actually diagnose or self-diagnose what type of dry eye you have, because a lot of the same symptoms that happen with aqueous deficient are overlapping with meibomian gland dysfunction. And this is, like I said before, one of the main reasons why dry eye is so underserved. It can easily be overlooked. It's not that it's, if you have, a problem with your appendix, there's certain tests that right away you'll know. With dry eye, it's wishy-washy most of the time. So that's why it's important when you go see an eye care professional that, you're telling them what your symptoms are. And at the same time, as a physician, you have to take the extra 5 minutes, ask the right questions, and really, really take the extra time to look at the front surface. Because there's a lot of things that can just kind of hide behind the curtains and you won't really notice it.
Well, again, fantastic information, Dr. Prosia. And is there a common myth of dry eye treatment that would shock our viewers?
Yes, absolutely. One that I think a lot of people might not know, believe it or not, but one of the most common myths of dry eye is that using over-the-counter tears, just artificial tears, are therapeutic. I know we've been told that our entire life, that using preservative-free artificial tears is a treatment for dry eye. And yes, in part of that, that's true, but there's a huge part of that statement that is false as well. Because we previously in DEWS 1, that study told us, dry eye is dry eye. That's what it is. But, as time has gone on, DEWS 2 has actually proven that it's actually more of an inflammatory problem. And so if we're just adding, artificial tears, it doesn't do much in the inflammatory aspect. Now, are preservative-free artificial tears good? They are, and I recommend them for every single patient. They're just not therapeutic on their own. They're very, very good supplemental therapy. And majority of the reason for that is they don't address the ocular inflammation and they don't address meibomian gland dysfunction. And when we talk about meibomian gland dysfunction, we're talking about causing 90% of all the evaporative dry eye, which is 80% of all the dry eye, right? So the analogy I use with my patients all the time is you have a pool in your backyard, you haven't had any time to clean it, and so it gets muddy. And so, you take the hose and you fill up the pool, and guess what? It's still muddy. That's exactly what the tears are doing. So what we have to do is we actually have to take a steroid or an anti-inflammatory or many different combination therapies, because dry eye is multifactorial, and we need to remove that muddy water. Once that's removed, AKA using a steroid, for a couple of weeks, then we can start to lubricate, clean the lids and lashes, and practice our good ocular hygiene. And then that's where the proper therapy comes in. And, personally, I've had a lot of success doing that.
Well, again, thank you for your information, Dr. Prosia. And you talked a little bit about screening patient history when conducting a dry eye exam. You mentioned glaucoma and diabetes. How do those issues tie into dry eyes?
Yeah, so, glaucoma and diabetes are the top 3 causes of blindness in the United States. And obviously we're trained to think, you have to know this, you have to know glaucoma, you have to know diabetes, and that's 100% true. But not a lot of people are talking about the fact that glaucoma and diabetes can actually, be associated with, dry eye, not directly in most cases, but in some different ways. And let's go ahead and start with glaucoma. So, glaucoma, as physicians, we have to remember, obviously, that we got to take a look at the nerve, but it's almost just as important to look at the front surface of the eye while you're doing that as well. And I understand that, the ocular surface has taken a backseat to glaucoma, and rightfully so. But as physicians, we can't have tunnel vision, no pun intended. What we have to really, really look at is that 80% in a recent study proved that 80% of glaucoma patients are struggling with dry eye. 80%. It's a vast majority of people. On top of that, almost 60% of those people had severe forms of dry eye. And so they did some more studies and they looked further into it, and they figured, was it caused by glaucoma or was it caused by the drops? And multiple studies has shown that based on the amount of drops that you use and the duration that you're on the glaucoma drops, it actually leads to a huge neurotoxicity problem. The preservative, and I've seen a couple of doctors on the OCuTALK talk about BAK, benzalkonium chloride. That is the most commonly used preservative in all glaucoma medications. We have it in some eye drops as well for dry eye. This alone can induce corneal neurotoxicity. And so when we have upregulated toxicity, upregulated inflammation, and reduced aqueous tear production, all from the overuse of BAK, you get dry eye. Now, what does that mean, neurotoxicity? Well, over time, basically those glaucoma patients that keep putting drops inside the eye, those nerves start not working as well. It's kind of like a burnout situation. And so we start going down this rabbit hole where the nerves that don't work properly, now we're not producing tears. Now we're not healing as well. And so we get situations of neurotrophic keratitis, which is a big one that is also overlooked. They say that it's rare, but neurotrophic keratitis and many different studies that have come out recently within the last year have actually shown that it's a lot more common than we think. And it's most likely due to the fact that this, BAK overuse. And so what we do in our practice, me and Dr. Ballot, is we follow the light trial. The light trial compared SLT laser and glaucoma drops, and it showed that the SLT is just more robust as a treatment. On top of that, it's more cost effective, and you don't have to use these drops. And with less drops, you can actually have these glaucoma patients not suffer from severe dry eye. Now, obviously, there's going to be patients that are going to have to be on drops regardless, but those mild glaucoma patients that can get that IOP reduction just from the SLT, that's extremely valuable because we can kind of prevent them from going down that rabbit hole of severe dry eye. Now, switching gears to diabetes, we've all heard of diabetic neuropathy, but we don't really understand that diabetic neuropathy could happen in the eye. Of course, we have a cranial nerve 5 and the cranial nerve 7, which are important for production of tears and also regulating corneal touch or sensation on the front surface of the eye. And when you have diabetic problems, 50% of people actually who have diabetes get neuropathy. And so that's a huge percentage of people who are probably suffering from neuropathy in the eye as well. So once again, we go down that rabbit hole of the nerves aren't working, you have delayed healing, you have healing, you have reduced tear production, and you get severe dry eye, another neurotrophic keratitis situation. And so those are the really two big things that we have to keep in mind, because all day long, I could count, 20, 30, 40 patients that walk in through the door who have diabetes and glaucoma. So if you're running a dry eye practice, you could find a lot of struggling patients just in the glaucoma and diabetes set of people that come into your office.
Well, fantastic information, Dr. Prosia. So you talked about your cases that you see most often. So what would the standard treatment protocol be for someone who comes into your office and has something to where it's mild to moderate dry eye? And
Right. So I would say this is probably about 30 to 40% of the patients. I deal with a lot of severe dry eye in the practice, but there are a lot of people that are coming through with mild to moderate who are just starting to experience the problems. And usually I customized based on their lifestyle, because not everyone, has the opportunity to put drops in all day long. And, I understand everyone works. And so I start off with, asking what they do for a living, how long they've been dealing with the issue, what other comorbidities they might be suffering from, like the ones we talked about, glaucoma, autoimmune, thyroid, and what they're currently doing to manage. Based on what they've been doing and how long they've had the problem for, that kind of gives me an idea where I can start. So, the general person that comes in, if they're mild to moderate, I basically break down dry eye in terms of levels. I have 5 levels of therapy that I offer. So these patients usually get level 1 to level 2. These involve, a steroid for acute inflammation that I also give them as a pulse therapy whenever they need it for their flare-ups. I usually get them on some preservative-free artificial tears, OCuSoft lid scrubs, of course, for the cleaning the lid and just overall hygiene, which is very important, as we know. Another really, really big one is nighttime ointments. There's a lot of people that sleep with their eyes open. And so adding a little bit more moisture at nighttime goes a long way. And then we talked about that anti-inflammatory diet and supplementation, and essentially vitamin C and GLA are my go-tos for that.
well, again, we love the shout out, Dr. Prosia. Thank you for that. So you talked a little bit in your last answer about eyelid hygiene. What about eyelid hygiene? What part does that play in dry eye care?
Yeah, so we understand that, majority of evaporative dry eye is due to MGD, or that majority of these patients have MGD. And so spending the extra 5 to 10 minutes to explain eyelid hygiene and how to do it goes a long way. Keeping the eyelids clean. I always use the analogy, listen, if you're brushing your teeth morning and night to remove bacteria and tartar so that you don't get that, cavity or mouth infection, it's the same thing with your lashes. We have a similar bacteria that harbors on our lashes and lids. And so if we can remove that and keep a clean surface, that it only aids in the meibomian glands to release the lipids that they're supposed to. And when they release those lipids that they're supposed to, obviously we have a cleaner, healthier ocular surface.
Love the eyelid hygiene talk, Dr. Prosia. Love it very much. So what do you recommend for long-term condition maintenance at home once the patients leave your office?
So when it comes to long-term at-home maintenance, of course, preservative-free artificial tears, OCuSoft lid scrubs, vitamin C, and then that GLA that I was talking about. GLA is very good, in my opinion. I'm not a big fan of omega-3s, just based on the DREAM study. But the GLA is phenomenal because it's been proven as an anti-inflammatory to actually improve aqueous production in Sjogren's patients. Not only that, it's the truly only viable precursor to one of the most potent anti-inflammatories in our body, which is a prostaglandin series 1. And so if we add that to our diet, something that can actually is proven to improve the aqueous tear secretions, along with eyelid cleaning and good at-home maintenance with tears and steroid pulse therapy, then that's going to help the patient a lot.
So do you have any recommendations for preventative care for someone how can someone avoid getting dry eye?
So this is a great question because I'm a huge on preventative dry eye care. It's very hard for someone to prevent themselves from getting dry eye just because of the nature of our eyes. Just like our skin, it's exposed to the external environment. And so at one point in our life, we're all going to experience dry eye. But what we can do to weather it is that we, practice, eyelid hygiene. We're adding artificial tears as much as we can. And, going to regular scheduled checkups so that we can see, how dry we are. If we're mild to moderate, we have no dry eye, or maybe we're severe and we don't even know. And in that case, hoping that, your physician will get you started on a steroid or something to, prevent any flare up or inflammation. But the big one for sure, my young patients that come in who are like 17, 18, I tell them, hey, listen, if you're on the computer for a lot, take a break, add some artificial tears and keep your eyelids clean. Those are all things that'll, by the time you get to, 30, 40, you'll thank yourself for doing it early on, right?
Very exciting indeed. Thank you, Dr. Prosia. And before we leave today, was there anything else that you'd like to let our audience know about?
Of course. Well, first and foremost, I want to thank you guys for having me on this podcast. It's an absolute pleasure to speak about dry eye because it's a passion of mine. And I hope what I've said today kind of inspires my current or future colleagues to focus in on the specialty of dry eye, because we definitely need more doctors that are doing this. But I want to end this podcast encouraging all of my colleagues to continue to research, learn, test yourself on your free time, because not only does it just help us as a physician, but it also helps give our patients better opportunities for successful treatments and just overall, improve quality of life when it comes down to the problem of dry eye.
Well, again, fantastic information, Dr. Prosia. Everyone, that was Dr. Julian Prosia. Dr. Prosia, thank you so much for joining us today.
Of course. Thank you for having me.